since suicide is we chose to focus the program this year on loss through suicide. First of all, suicide is a very terrible kind of loss. Every loss of a loved one is a terrible loss. I think loss through suicide has unique features. There are about 50,000 people in the United States who die through suicide. And there are all those around them that are left with the impact of that. There are 4 times more men who die by suicide because of the different and more lethal methods that men tend to use. And we have very great reason to worry about Gen Z, namely those between age 14 and 25, who are at historically high levels for psychological distress. So new analysis by the CDC shows us that about a little more than 19% of the adolescents in that age bracket are screening positive for depression, which is a very highly correlated mental health disorder when we look at suicide. And 94% of them report regular sources of stress, and 56% of them report spending more than 4 hours a day on social media. The United States Surgeon General issued advisories that adolescents who spend more than 3 hours a day on screens and on social media more than double their risk for depression and anxiety. We also see from neural imaging that watching screens to that extent sort of hyperstimulates the areas of reward and impairs the areas that have to do with impulse control. So all of these things, as we know, are going to be risk factors for impulsive suicidal behavior, especially in the backdrop when there is depression and anxiety in the backdrop. We also know that in terms of the demographics, the highest level of suicide is amongst the geriatric population. And one of the issues that we have become more aware of recently is the so-called epidemic of loneliness. But we are also seeing a different kind of problem that leads some older people to kill themselves, which is when there are more than 3 people in the household, which is an interesting sort of contradiction, if you want, which shows us that it's not just whether you have people around you, but also what is the nature of the relationships and the interactions and the reasons why people are there or not there. We also, of course, are aware of the fact that the rates of suicide amongst veterans are more than double in the non-veteran population. And that really, I think, is also important to mention in that context that some recent studies show that amongst veterans, the level of felt moral injury is very, very highly correlated with risk for suicide. So that tells us that it's not just PTSD that we have to look at, but also this very different aspect of impact of traumatic events that we perhaps have not been paying enough attention to. And yet, despite all of these things, the visibility of suicide in public discourse is insufficient, as if speaking about it is somehow inappropriate or something that is avoided. And even less is discussed or talked about with regards to the surviving relatives of these people. How do surviving relatives manage their feelings after such a complicated loss? and how are their lives and relationships impacted by this kind of a loss. On a personal note, I will say that in this past January, my family marked the 2-year anniversary of the suicide of my nephew. He was the firstborn grandson in a family established by 2 Holocaust survivors who lost their families and established new families and had 3 children in an attempt to rebuild and perhaps dissociate to some extent from their trauma and from their loss. But the birth, while we, the children, were the hope for the future, the firstborn grandson was the confirmation of normalcy, that we again were seeing families like ours become normal families with generational continuity. All of us, not just my nephew's mother, but my brother and I, who were very young, and he was the first, as I said, grandson in the family, all of us were very intimately and deeply involved with my nephew throughout his life, and we mourn his loss very deeply and very profoundly. So I am very grateful to the 2 speakers who agreed to be with us today to discuss this topic. And with that, I will present to you Adele Raemer and Deanna Finizio. Adele Raemer is a suicide survivor who was widowed in November 2008. She is also a survivor of the October 7th, 2023 massacre in Israel. She's an American-born Israeli who has lived in Kibbutz Nirim on the border with Gaza Strip since 1975, and she believes that people on both sides of the border deserve better security and quality of life. Deanna Finizio joined the New Jersey chapter of the American Foundation for Suicide Prevention, AFSP, in July of 2022. Deanna holds a bachelor's degree in public health from Rutgers, the State University of New Jersey. As the program manager, Deanna leads the implementation of AFSP's prevention education programs across the state, including the recruitment, training, and support of volunteers who help bring these initiatives to communities throughout New Jersey. Thank you very much, Adele and Deanna, for agreeing to be with us today. And it is really my honor and my pleasure to give the space to you, Adele.
Thank you very much for having me. Please, perfect. I'm going to read a little segment from my diary first, and then we'll have an open discussion. Among other things that I do, I'm a blogger on the Times of Israel, usually blogging about the security situation here where I live on the border, but also about loss through suicide, because as Irit said, it's as if mental illness and especially suicide is something that's taboo and can't be spoken about. And like in the Harry Potter books, they wouldn't mention the name Voldemort, and not mentioning the name makes it even bigger and scarier and more
Ominous
and threatening. And I don't want to do that. I think it's really important to talk about mental illness and to talk about suicide and to look it in the eyes. So on November 13th, 2008, around noontime, my life changed forever. Losing the love of your life to depression-induced suicide is not the same as losing your loved one to a physical disease. It's not. An ill person fights back, even if passively. A person who commits suicide has given up not only on himself, but also on his loved ones. I know he was in terrible pain. I know he was frightened by the prospects of having to deal with this abhorrent bipolar roller coaster of formidable yet exhilarating highs, and then the inevitable devastating lows for the rest of his days. As if that were not challenging enough, cancer flippantly tossed itself into the equation, gnawing away at his back, pushing him over the edge. But I also know that the fact that he gave up his fight for survival means that we, his family, weren't enough to love for, to fight tooth and nail to survive for. Is it selfish of me to think so? Maybe. But it was selfish of him to leave. He promised me, he swore to me that he would never hurt himself. He lied. Laura used to ask me, how much do you love me? My staple response was always, more than yesterday, half as much as tomorrow. What happens when there are no more tomorrows? So I wrote this after 13 years. And I felt it sort of sums things up for me. So I wanted to start with that.
It's very hard to speak after hearing this, Adele. I think, go ahead.
No, I was going to say that's why I have my OIV cup.
OIV cup, exactly. And I should get myself one like that. I think that what you said there is unbelievably courageous, and it calls by name things that people don't really allow themselves to say, even to ourselves. I speak from experience that it's very hard to actually face the feelings that you mentioned, such as, we weren't enough. We weren't enough. How could he do that, right? How could he not think about what he's doing to all of us? And I think that is very important, to be able to acknowledge the unusual, as you said, when someone dies because they are ill, someone dies because of an accident, it doesn't have that added aspect of abandonment, of having been not sufficiently important to merit a fight.
Indeed. And Laurie left behind not only his mother, who was still alive,
Wow.
and his sister, his sons, and our youngest was not 18 yet. And I often ask myself, there's a saying in Hebrew, when something hurts you very deeply psychologically, that you're scratched, like an LP record. When you have a scratch in that record, you can hear the music again, but it will never sound the same. So when he left us, he scratched us, he scarred us emotionally, psychologically for the rest of our lives. And And I wonder, I ask myself if he ever thought of that, because as I said, he promised me that he wouldn't do anything to hurt himself. Um, Unfortunately, a year after he shot himself, my son was diagnosed with depression and then eventually bipolarity as well. And the fact that his father committed suicide for me is even more petrifying, because it's in a way, when somebody you love does that, it sort of opens up a door and makes it legitimate, a legitimate out, and that's what scares the hell out of me. Thank God he's has it under his bipolarity under control, but it's a dark cloud that will hang over us for the rest of my life, for the rest of his life.
Absolutely. I have two young adult daughters, and uh, it is very scary. As you say, we know, actually, statistically speaking, that families in which suicide took place are at greater risk for other suicides. And it is a very, very scary, scary thought. Absolutely. How did you explain what happened to a almost 18, not even 18-year-old son, or even the older kids?
Um, I can't remember if we went to therapy together. I know that I went to therapy for a few sessions, um, and more in order to know how to talk to my kids about it. I also have two older daughters that were from a previous marriage. Um, how do you? I don't remember how I explained it to him. Um, but we were all in therapy, and he was still in high school, so he had his advisors there, and his older brother, who, although he wasn't that much older, is also very wise, and took him under his wing and became his father figure, and still is
Still is.
his father figure. Um, for me personally, I went to therapy just like 3 sessions and then figured, okay, I've figured it out, I've got this, and then didn't deal with myself um, until 2011, which brought me to um, a medical clowning course, which I did in order to become a medical clown. Um, and I told everybody when it was over that this was the best therapy, just learning the tools of medical clowning and becoming a medical clown myself and going into hospitals and cheering people up and taking them virtually out of their horrible situation and scary situation in the hospital for a few seconds. That for me personally was the best therapy I could have gotten any place. And I still believe that it is true till today. Um,
That's a remarkable thing that you managed to do, you know. I mean, we do know that some people manage to get some incredibly positive um, outcomes, even from the worst of situations, and take it to some amazingly beneficial places for other people. We call it post-traumatic growth, right? Not that anyone would imagine choosing to have gone through what they went through, but nonetheless, some people manage to get all kinds of newly found recognitions of their own fortitude and to be able to do things for other people that are incredibly beneficial, as I'm sure what you do is. And it struck me that you said this very interesting thing, buying a few moments of relief from the sorrow and the worry that these people experience who are in the hospital. And in a way, it made me think of, as I said, I started my career in emergency psychiatric services, and I've always continued to be interested in suicide prevention. And we often say that what is very important is to create a plan, that will allow the person to have very clear ideas of what they might do
I'm okay. How are you?
in those acute moments when the suicidality is very, very intense. If they can just do something for a few seconds that might give them the space between that acute impulse and acting on it. Mm? Because a long time ago, I think the idea was, and I still remember in the very beginning when I was still doing my internship at Yale University, we would have safety contracts with patients. We would have them sign that they would not hurt themselves or kill themselves until the next session, right?
Wow.
But that was really, it was proven insufficient and not really useful at all, because when that wave of acute suicidality comes, people don't seem to be able to hang on to that because it only told them what not to do. And what we actually need to do is create together with them a very concrete safety plan of
Wow.
specific steps that they need to take when that happens that might give them those few seconds before they actually act on it.
That's amazing, because I always say that my husband did not leave a suicide note, and I truly do not believe that he planned it. He, I, the day that it happened, I'd gone to work. I had a meeting in Tel Aviv, which is a train ride away and a 2-hour ride away from where I live. And I'd debated with myself, I deliberated whether I should be going or not. But he was at the stage where he was functioning to a certain extent. I would leave him a list of tasks to do, chores that he had to do every day in order to get himself up and moving. We'd had a plan for that morning that he was going to go out into the fields with my stepson, with his son, Daniel, because he was working in the fields on the tractor, and Laurie was a farmer, and he loved being out in the fields. And the plan was that he was going to get up that morning. I mean, before I left the house, I saw to it that he was up and dressed and out of bed. And I kissed him goodbye and left him in the easy chair and went on my way. And he was supposed to go to the infirmary to have his bandage replaced, because I said he had a cancerous growth on his back and it had been operated on. And we were waiting for an isotope test the following week. So he went to the infirmary, had his bandage changed, went into the dentist's office, made an appointment for the dentist the following week, got on his bike, and our house and the infirmary is like a 3-minute bike ride. Got on his bike and As he was riding home, he passed by the place where he knew that the weapons for guard duty were kept. And on kibbutz, we used to keep it in a house, in a room in the baby house, the place where the babies are during the day. And every man on kibbutz who would do guard duty knew how to get to the weapons and knew where they were. So he, in my mind, in a moment of madness, as he was passing by on his bike, he looked at that baby house, got off his bike, walked in, took the weapon, and shot himself. And if he had had a plan, I guess, of what to do when he was having these thoughts of, I can't do this anymore, maybe that would have saved him.
Maybe, because when we do these analyses after unsuccessful attempts or successful attempts, yes, there is oftentimes there are things that indicate that the person actually indicated somehow they were giving their things away, they were saying certain things, and here you actually have counter indications. Who goes and troubles themselves and other people to make an appointment with the dentist for the following week when they're planning to kill themselves in a half an hour, right? It is so.
In 3 minutes.
In 3 minutes, exactly. In 3 minutes. Who does that? Why would you do that, right? So this is, in some ways, this would be the very strong kind of example to what some of us in this field say, and that is really the in intolerable, momentary, acute, impulsive wave, the wave of pain and the impulsive response to it, which is therefore such a good reason to create something that intervenes in those few minutes just to get a few seconds, like you say, 3 minutes between his dentist appointment and him killing himself. There could have been another 30 seconds between that and something a very different outcome. And Anat Bronstein-Komek, who works in Israel, a psychologist who's very much in the field of suicidality, speaks of, just like we have CPR, that everybody should know CPR, she says everybody should know what she calls QPR, which is an acronym for question, persuade, and refer. And she says these are the acronyms of a certain skill, like CPR, of how to question someone, whoever it may be, your coworker, someone sitting next to you on the bus who seems very despondent, anyone. And she says we all should have that skill of addressing someone that we think might be in in at risk for killing themselves. And then, of course, there are very, very now, I think, much clearer plans than I remember them being when I was doing emergency psychiatric care. We did have many of the ideas were very clear, that about the need to intervene in those few seconds to have a plan. But I think now we are much more aware of it, the need for a very concrete plan that includes both things that people can do by themselves, like what kind of things would be the best distractions for you in that moment. And it's very individual. What would you do? Start singing a song. I don't know, watch TV, turn this on, do that, go for a run, whatever. And sometimes even very small and invisible things that one can do that are more in the domain of sort of, muscle relaxation, muscle uh, uh, breathing, things that you can do no matter where you are without even other people seeing you do that or recognizing that that's what you do. And then, of course, further steps that involve who specifically would you call? What is their work number? What is their cell number? What is their home number? And if that person is not there, who's the next one? And if they're not there, who else can you call who is a professional, and what's their number, and where is the next ER? If all of the above failed, where is the next ER? Do you have money for a cab to take yourself to the ER? I mean, very specific elements of a plan that might just give somebody that little window before they act on it.
An escape route.
Yeah, an escape route from that horrible wave that allows you then to be back in the space where you can think of the people that you love and that you don't want to leave them, and that it would be terrible for them if you leave them, and all of those other reasons for living that you can't think of in that moment of acute suicidality, right?
And I was so, one of the things that I read afterwards, a cousin sent me an article about two mothers who lost children to suicide. And one mother, one of the patients had been hospitalized, and the other one refused to be hospitalized. And when the mother whose child had been hospitalized, when that child killed himself, she said, "Oh, why did I make him go to the hospital? If I just kept him at home, then he might be alive today. Maybe that's what pushed him over." And the other mother also said, when her child committed suicide at home, "Why didn't I make him hospitalize him? Maybe that would have saved his life." And it's just, when a person decides that that's it, stop the world, I want to get off, sometimes nothing is good enough. Nothing is going to change their minds.
Yeah.
Something that helped me understand his depression was a book by William Saroyan, who himself suffered from depression, and he wrote Darkness Visible.
Right.
Visibilized.
No, Darkness Visible, I think. Yeah.
And it gave me an insight, a little bit of an insight into understanding that just in the way that I see the world through rose-colored glasses, and I really do, because that's just me. He, when he was depressed, was seeing the world through a thick, dark, black veil, and couldn't see anything through it, and couldn't see the way out, couldn't see the light at the end of the tunnel.
Yeah, exactly. And you also mentioned the issue of the letter. He didn't leave a letter because I do think that it's most likely the way that we just said, it's most likely it was a very impulsive decision. Do you think that would have made things any easier for you or the children? Is there anything he could have said in a letter?
No, I think in a way it would have been even more painful if I'd known that it was something that had been planned,
Right.
rather than something that was a moment of madness.
Right.
But that's regarding those who are left behind.
Yeah.
Regarding him, I mean, maybe it would have stopped him if he'd been. I mean, he wasn't in a situation. In his depression, he was not in the kind of situation he could even really leave a letter. He
Yeah.
wasn't really he had a diary. I made him keep a diary and write what he did each day, and that was about the limit of what he was able to do. He wasn't at that stage anyway, but
And he was in treatment.
he was in treatment with one of the top psychiatrists in the country. And the psychiatrist came to me afterwards when we were sitting Shiva. And he said the whole time he had said he's not dangerous to himself or to the people around him. And he said, I so did not see this coming.
Yeah, and this is really something that is a very, very frightening thing for therapists to deal with. I don't think that there's any way that anyone who has been in the field long enough and sees people, um, well, I don't think that there's anybody who can believe that we can prevent everybody from committing suicide. And it's
So when
really,
that first,
go ahead.
so when he first was diagnosed with depression, um, I I had a gun. I had a pistol license, and he had an M16 as somebody who was one of the first responders. And as soon as we got that diagnosis, I got rid of the guns. I gave them away. I said, "No guns in this house. Keep it away from him."
Which is really something that not everybody does soon enough. But you know, my nephew killed himself with a kitchen knife. So, you know, it's very, very hard to make sure that people don't act. There is, if someone has that very, very strong impulse to do it, it's very, very hard for us to make sure that that won't be possible. There are always ways. Yeah. I uh, I was going to ask if how did it impact the relationships in the family?
I think it brought us closer. My two eldest, who were his stepdaughters, were already out of the house at any rate. And I think with the youngest, who was our common child, um, I think it brought us closer. But when I talked to my son about it, who's now 35, I just last year found out from him that there were times that he was scared of his dad, that there were all these feelings that I had no idea that even existed, that he felt threatened by him, especially when he was on his ups and downs. And so I feel very close to him. Um, and probably even more so because of the fact that I was left a single parent.
You know, you said that you look at life through rosy glasses, and I imagine also that in this darkest of times, right after it happened, the fact that you had to go on for the children was of tremendous importance, right?
As we were driving, as I was being driven home,
Mm-hmm.
I was in Tel Aviv when it happened. And I found out by two people from my kibbutz who were in Tel Aviv, and they were told about what happened, and they were told where I was and to come find me because I was seeing all sorts of messages. I was a teacher in our school, the same school where my son went to when he was in the 12th grade. And I saw all of these messages telling all of the teachers to come to the teachers' room immediately. And I'm in the middle of these meetings in Tel Aviv, and I didn't understand what that was about. But I saw it, and I figured, okay, when I get home, I'll find out what it's about. And the two people from my kibbutz who came to tell me, we were sitting in a restaurant, and they came over to me and they said, Adele, we'd like to take you. We have something to tell you. And they walked me to the back, to a back room in the restaurant, and chokingly, idiotically, I said, "Is this a surprise? Something you're starting to scare me." Like I was so sure this was going to be something, a surprise party or a surprise. I don't know, something positive because that's what I always expect. And they sat me down and they said, "Lori's dead." And the poor people that were sitting in that restaurant, they didn't know what hit them. They're hearing some crazy lady screaming at the top of her lungs. And on my way back home, all I wanted to do was open the door and jump out of the car. And if I hadn't had the children that I knew that were waiting at home and would need me to be there for them, if we hadn't had any children, there would have been no reason for me not to. Just
Yeah.
jump out and join them.
Yeah. Well, you know, in there's a book by someone who wrote in Israel, a book about surviving his sister's suicide as an adolescent and how important it was to him when he could first see his parents smile again. So I am so grateful to you for telling us this story and being with us. And I will turn the mic now to Deanna, and then maybe there will be an opportunity for some Q&A and some further comments. Thank you so much, Adele. You are
And,
incredible.
and thank you and all your colleagues for all you do to hopefully prevent even one person. If each of you just prevents even one person, can help one person step away from that ledge. You guys are amazing. Thank you.
Thank you, Adele.
Thank
Deanna, hello.
Hello. Okay. Let me just share my screen and then we'll get started. Okay. Can everyone see the slides?
Yeah.
Perfect. Okay. Thank you again so much, Adele. Thank you, Irit and Felix and the NGO Committee on Mental Health. I am so grateful to be here with you all today. I am honored to really just have the opportunity to speak with you about suicide loss. So my name is Deanna Finizio. I am the Programs Manager with the American Foundation for Suicide Prevention's New Jersey chapter. I know that's a mouthful, so we have an acronym, AFSP. We are a national nonprofit organization where our mission is to save lives and bring hope to those affected by suicide. So hopefully you all have heard of us before. If not, I'll tell you a little bit about our organization in a bit. But I also want to highlight that I too am a suicide loss survivor myself. This is how I really got into this work. My family and I were actually looking for resources in New Jersey, and we stumbled upon AFSP. My 24-year-old cousin, Danielle, lost her battle to depression and anxiety and died by suicide in 2016. She was a daughter, a sister, a cousin, a friend, a registered nurse, and just an all-around amazing person. Anyone that knew her knew that Danielle could light up a room just by walking into the room, and that her laughter was contagious, and she could make anyone's bad day better. But despite her struggles with depression and anxiety, she still dedicated her time to her friends, to her work as a nurse, and always put others before herself. Unfortunately, her battle with depression, cooped with a newly diagnosed kidney disease, became too much for her. Danielle is missed and loved so much by her loved ones, our friends, her community, and her love and spirit will live on. So we remember Danielle's beautiful life and how she cared so deeply for others. And this is my why. Her story, Adele's story, and so many other stories are truly heartbreaking. But this is where our passion for supporting others, for supporting loss survivors comes from, and to raise awareness for mental health and suicide prevention. And I know, or I'm pretty certain that a lot of us in this room today have been touched by suicide in some way. So just know that I hold space for you here. I would love to, have conversation in the chat. We want to support one another as best as we can. And I will provide some resources at the end of the presentation too. But more specifically, my presentation will focus on more from an organizational perspective, but also as a suicide loss survivor. So we're really going to talk about understanding the unique challenges of suicide grief, which really ties into the conversation that Adele and Irit just had, providing tools and techniques to aid in that healing, right? How can we help support our loss survivors and ourselves in this lifelong journey of grief? And then, of course, we always want to make sure that we're providing the necessary resources for healing programs and initiatives. And we want to become familiar with those resources just in case either someone is in crisis, we've experienced a loss, or someone needs community support. So our mission at the American Foundation for Suicide Prevention, it keeps on going to the next slide here. But we are a national nonprofit organization that gives those affected by suicide a nationwide community, empowered by our research, our education, and our advocacy to take action against this leading cause of death. So you see our mission here is to save lives and bring hope to those affected by suicide. And we prioritize mental health and suicide prevention and loss support in a number of different ways. We fund over $30 million in suicide prevention research annually. We educate the public with our free prevention education programs, and we advocate for public policies that support mental health and suicide prevention. And of course, why we're here today, we continue to support survivors of suicide loss and those affected by suicide with specific programs and resources. So if you want to learn a little bit more about us, our website is at the bottom of the screen. Again, I'm just honored and grateful to just have this stage to really talk with you all and have a great conversation. So first, I want to begin with just an analogy that I found to be really helpful. This was brought to my attention in the beginning of my grief journey, and it's stuck with me. So when our person died, it's as though we suddenly have this enormous weight attached to our shoulders, right? It's so heavy, and we cannot even get out of bed or function in those early days, months, even years. I remember not being able to do the simplest of things. But one day at a time, 1 week at a time, as we learn to strengthen those muscles, we need to carry this enormous weight. This burden becomes a little bit lighter. And you might be a little surprised at how much lighter it becomes down the road. That grief stays with you. It's never truly gone, but it becomes lighter. One day, we hope to really train those muscles so that the weight is not so much to bear, And with work and in time, it does feel lighter. That weight is still there, though, as I mentioned. It will never go away. It will not actually leave our shoulders, but you learn to carry it. So for me today, in this moment, the weight feels light for me right now, and manageable. And, I get up sometimes and not even notice. Or, I think about it, and within a minute, I'm thinking about another task. But it's always there in the back of my mind, right? I'm always going to remember Danielle in some way. Or some days I have days where anniversaries, her birthday, where those muscles tend to be more fatigued and tired, and I can barely move, or I feel myself really struggling and looking for that extra support, and that's okay, and that's normal. But I know that they're just tired. I'm just tired, right? I will continue to train them, to nourish them, and I know that I will be okay. So wherever you are today with your loss, whether you are newly bereaved, supporting someone who's newly bereaved, years out, we must always tend to those muscles. We're always going to have self-care within ourselves, put ourselves first, and we must consistently tend and nurture to ourselves. So that's something that, someone has mentioned to me many times, and I wanted to just share with you all. But that's the process of healing. And it's going to look different for everyone. So just be patient with your grief journey, and know that there are so many resources and support out there for those who are struggling or feel like they're stuck in their grief. So understanding grief after a suicide loss. This is somewhat what we wrote in the chat already, but when we look at suicide grief, we know that it is devastating, but it is very complex. So we know that it is unique and personal. Everybody grieves differently. Each suicide death is different. It is as individualized as our fingerprints. And it is so important to remember that we each have our own unique relationship with our loved one, with that person who died. No relationship will be the same. So individuals will certainly have different feelings that come up. Anger, disappointment, frustration, sadness, the list goes on. Those are valid feelings. And then in turn, we're going to respond and act in a certain way. So for example, one may find comfort, like I did, staying at home with my cousins under a blanket, watching, Danielle's favorite movie. While other people, they need to get up, they need to go out, they need to move, they need to keep busy, right? They need to stay focused on something else. And both of those things are okay. There's no right or wrong way to grieve. And every response is real, it's fair, it's necessary for that person. So being aware that grief may look different for everyone, to those who are close to us, to our family, I'm going to grieve differently than my parents, than my siblings, can help again with that healing process. And we know that grief is not linear. It is not organized. It is messy. It's unpredictable. Just because grief may look like it's moving forward in a straight line does not mean that one is moving backwards, moving forward, moving side to side. It's going to be different. It's not linear. It is a process. It just means that things might come up at a time or another, and maybe things need to be addressed. Maybe we need to take a pause. Maybe we need to sit with this feeling for a little bit and talk through it. And that's okay. And all of your emotions are real and fair, right? We always want to make sure that your feelings are valid to you, and that's okay. You're allowed to feel the way that you feel. And it may help lost survivors to understand that suicide is complex. I know we mentioned this in the chat. There are going to be many stressors and risk factors that Irit was mentioning before that are converging at the same time, right? We have our risk factors, our life events, and they're all going to be converging. So we need to remember that it's a very complex death. It is its own disease. It is a public health problem within our nation. It is, we know that the person who dies by suicide has an unhealthy brain, right? Through our research at AFSP, we've learned this. So, we know that it's also going to be different for everyone. There's going to be different reasons on why. So just give yourself grace. There are going to be a lot of why questions, and I know we've had this conversation a little bit already, but we want to frame suicide in a way that stops that stigma within a suicide death, right? We want to change the conversation around suicide, and we want to encourage those who are struggling to seek help, to come to us when they are in a crisis. Back to what Irit was saying before, we want to help them create that safety plan. We want there to be things in place that if they're feeling like they're in this crisis moment, we want to help get them through that moment. So, understanding grief is going to be different for everyone, and it's going to be very complex. And this is just a little picture that I put together. The expectation of grief versus the reality of grief. We think it's going to look straight, and we're going to build on those blocks, and it looks neat and pretty, but it's going to be all squiggly, and we're going to be going in different directions. And, we're going to learn through our process who helps us through this journey, what helps us, what are the coping mechanisms, whether that's therapy, medication, a combination of both, a support group, books, about suicidality to get us through that grief journey. And again, we just want to give ourselves some grace. So after a death by suicide, there are going to be some unique challenges, some that have been brought up already, some that might be new to the conversation. In many ways, the feelings one might experience after a suicide resemble feelings following other kinds of death, right? Especially when that death was sudden, violent, or traumatic. But we know that suicide is unique in its nature. But then a death by suicide occurs, and in addition to the emotions we discussed, loss survivors are going to experience a variety of feelings themselves, as you see here. Rejection, abandonment, anger, humiliation, right? They're not going to believe it at first. That was how my family was. This isn't possible, right? Survivors may also experience stronger feelings of guilt, blame, responsibility. Why did this happen? What could I have done to prevent this? I didn't do enough to help Danielle, blaming myself for a very long time. Again, that was normal at the time, right? Thinking these things. Why did this happen? And suicide loss survivors often feel that their grief is unique, and that only suicide loss survivors can truly understand what they feel, and that they feel isolated for a time, maybe even judged or blamed. In the beginning of my grief, I didn't know anyone else who lost a loved one to suicide, and I felt isolated and alone. And I was young. I was 21 at the time, and I didn't know who else to talk to other than my friends and my cousins, who were also grieving, but we were all grieving differently. So I felt, well, is someone going to judge me if I want to talk about this? Or, if I feel like I'm blaming myself, what are they going to say to that? And it can really be helpful, when we start connecting with other loss survivors, that lived experience, that support, that community. We all don't want to be in this community, but we are. It is unlike anything I've experienced before. The amount of friends and love I have throughout loss survivors that I know, they've helped me get to where I am today. And I'm extremely grateful. And I hope that I can continue to do the same for those who are maybe in the first years or months after a loss. So we want to lean on each other, and we want to lean on those support groups if that's for you. If not, that's okay, right? It's going to be unique and different for everyone. And just to continue this trend, suicide loss survivors may struggle with what to tell people about the death. I know Irit and Adele touched upon this a little bit before. Not all suicide loss survivors are comfortable sharing that they lost a loved one by suicide, right? Will I be
Right.
judged? What are they going to think about me and my family? Or are they going to talk about my loved one? Are they going to gossip about me and my family? Right? That's valid. They may have a hard time maintaining contact with friends and family and experience waves of sadness and grief. When their support network doesn't know what to do or say, they may feel isolated and abandoned, embarrassed, overwhelmed. I actually remember in the early months following Danielle's death, there were some people that I was surprised kind of left me. They didn't know what to say. They didn't know how to support me. And they thought that it would just be best to not contact me. And in that moment, I felt, did I do something wrong? Should I not be bringing this up because it's going to make other people feel uncomfortable? And I felt abandoned by my friends. But then you see other people that you wouldn't think would kind of come to your need and support you were there for you. And that was truly just something that I will never forget. And those are the people that weren't afraid to have these conversations about suicide or not even know what to say. Just say, hey, I'm here to talk. I'll listen. I might not have all the answers. I don't know what to say, but I'm going to be here for you. And those are the people that you need in your corner. And it's not that the other folks that kind of, left did it harmfully. They thought they were doing the right thing for me. And again, this is how we want to change that conversation. We want others to be educated in what are ways to talk to a loss survivor, because it's going to be different than another death, right? We know that. So people may find it challenging and uncomfortable and awkward, but it's not their intent to make the loss survivor feel out of place, but it might happen. They may also find it challenging to navigate or experience anniversaries, birthdays, and holidays. That's what I mentioned before too. Those are always going to be the big days that I feel heavy, and that's okay. And any way that you need to grieve in those moments, you do what you have to do, right? And as time goes on and healing progresses, survivors may feel a mixture of positive feelings along with waves of sadness. In the beginning, so when she passed, I was 21 and Danielle was 24 when she died. And when I reached my 24th birthday, I felt a wave of sadness because I outlived her, and that was never supposed to happen. And that took a lot for me to really get through. And but I also felt joy that I wanted to celebrate my year, right? So there are going to be, things that are happening in life, like my wedding, where she should have been there, but it was a very joyous day, but I had a little wave of sadness in there, and that's okay. Experiences, like a sense of gratitude to have known the person. I'm even lucky that I got to experience Danielle because she was the best person I've ever met. And positive memories. I talk about her all the time, and appreciation for, who she was and how much of a light she was and still is in my life. So also to continue this trend a little bit, when we talk about cultural influences. So culture may significantly affect the way people view and respond to suicide and death. And here are just a few things to consider. So we want to be mindful that people may or may not be comfortable talking about suicide. And in some cultures, suicide may be viewed as a moral failing of the individual or the family. We want to be sensitive to the beliefs and customs of a lost survivor and their family, right? We want to allow the family to decide when and how to share the news of the death and how many details they would like to share. We want to be aware there may be specific rituals within that family, around a funeral and grieving that are very different from what we believe. Some people are more comfortable speaking about mental health openly and encouraging help seeking than others. Also, different generations, even within the same culture, may have different levels of comfort talking about mental health. We see that a lot. More of the younger generations were more open to having conversations around mental health and, help-seeking behaviors. Whereas, my parents and my grandparents, they didn't talk about mental health. They, you're okay, just live with it, move on, you'll be fine. And they kept that hidden, and they couldn't open up and talk and have these conversations. So that the amount of isolation that they must have felt if they were ever going through a crisis moment, right? It's sad. But there is no one way to grieve a suicide loss. And you may find that those around you are grieving, again, in different ways. So it's really important to allow space for yourself and those around you to grieve in the way that they need to. And people who identify as LGBTQIA+ and experience suicide loss may face additional stressors, like not being allowed to publicly grieve that loss. So, for example, their relationships may not have been accepted by those around them, maybe by the family. And they may not be allowed to attend the funeral or other rituals. Also, when we talk about our service members and veterans, their families, right? They often lose that chance to stay connected with others who have been affected by that loss due to frequent relocation. If they're in a specific squad, military culture comes into place, that distinct sense of accountability, right? Maybe there was a loss within a unit, especially for leadership. They might feel responsible or feel like they're blaming themselves. That accountability. Those are just two examples, but it is important to remember that individuals, even within the same culture, can have different experiences, beliefs, and desires. So when you are unsure of the best way to support a suicide loss survivor that may come from a different background than you, the best thing to do is ask them. Just be upfront, be honest, be open, be non-judgmental, and honor their wishes. And sometimes that might be hard for people to ask. But when someone asked me how I wanted to, not so much grieve, but how do I need to process what happened, right? That actually made me feel seen, and it helped me understand that people want to be in my space and they want to support me, and they're doing the best that they can to try to support me. And I appreciated that. So grief and mourning. This outward expression of loss helps suicide loss survivors move in their grief, right? From grief to mourning. So examples: talking, therapy, trauma work, support groups, writing, creativity, playing or listening to music, exercising, walking. The idea is to openly express those feelings. Our grief is our inside response to the loss, and mourning is essentially grief gone public, the getting it out, so to speak. So active mourning will help us heal every day. Encouraging these actions to suicide loss survivors is so important. And we know we will never get over our loss, but ultimately we want to reconcile our losses into our lives, right? We want to move with purpose, and we want to hold that space for our loved one, but we want to continue on. So not only is our loved one's story important, but it's a part of our own story as well. I wouldn't be doing this work if it wasn't for Danielle, right? I wouldn't have found AFSP, and I wouldn't be working with the amazing people that I work with today. So Dr. Alan Wolfelt, a renowned author, educator, grief counselor who has written over 100 books about grief and loss, has outlined the 6 needs of mourning that will really help suicide loss survivors reconcile or integrate the loss into their everyday lives. So again, these are going to take time to be met. Remember, there is no reward for speed. You don't get a gold sticker once you hit, number 6. It can take as long as we need. And this is, again, going to be lifelong. So one is, it may take time to process, right? We want to acknowledge the death. Some of us don't want to face the reality, right? I needed to move from my head into my heart. I needed to accept that this happened to me and my family. I had to acknowledge that my cousin died. And eventually, loss survivors must acknowledge that this is our reality, unfortunately. As much as we don't like it and we don't want it to be true, this is our reality. And we want to embrace that pain of loss. As terrible as that sounds, we want to feel it all. We don't want to deny our pain. We want to lean in at times, but then at times we want to distract ourselves. And we can't skip this part. This is where a lot of the healing is going to be coming from. As much as it's painful, it is necessary to sit with those feelings safely, I might add, with a mental health professional. Letting ourselves go to that place that's uncomfortable will actually help us move forward in our grief. And we want to remember the person who died, right? Affirm the value of the life that they lived. We want to talk about them, carry them with us. Our relationships can continue, right? My relationship with Danielle has continued in a different way. We want to share photos, tell stories about them, cook the foods that they like, explore the hobbies that they liked, continue to say their names. We want them to be remembered. But we also want to, or we might have to, develop a new identity. I'm not the same person I was in 2016. It takes time to become familiar with this new landscape of life. You may take on new roles. You may leave some behind. You may develop, again, a new circle of loved ones, of friends, of community. People come and go in that aftermath, as I mentioned, right? There might be lifelong friends who disconnect, acquaintances who show up. We want you to take your time to figure out the new you, figure out this new rhythm as your responsibilities might shift. You may discover and develop new aspects of yourself and your relationships to assist in your healing. And we want to search for meaning. This death brings up so many questions, and families, friends, communities are broken. We say that with every suicide death, there's that ripple effect where it's not just the family, but it's the friends, maybe place of worship, your school, your community, your state even, right? Every ounce of that person's life is somehow going to be impacted. And it might force us to confront some form of faith or spirituality that one expresses. We might ask those questions. We might rage at your version of God, right? Question life, explore different types of spiritual values. We want to look for the meaning of our continued living, of our continued life. We want to, for me, joy and pain can coexist. And I enjoy the happy times, but I also acknowledge the sad times. And I sometimes want to sit with those emotions, acknowledge it, and then I want to move forward. Because this is why we're all here. We want to experience all of life, to learn, to grow, to heal for us and for that person as well. And then we want to receive ongoing support. This is the most important part. We want to reach out for help. You cannot do this alone. It takes a village. It really does. Surround yourself with people who will let you feel and sometimes just sit within your grief. I'm almost 10 years out from my loss, and I still ask for help and support. I speak with other suicide loss survivors whenever I can. I read about suicide loss. I listen to other people's stories. I'm always up to date on the latest suicide prevention trainings. I surround myself with people who will let me feel and who continue to support me in my grief. So here are just some key things, again, that seem to really work within a healing journey. Therapy and counseling. We need to find an unbiased and safe professional to share and to guide through our thoughts. AFSP has a list of clinicians who are knowledgeable about bereavement after suicide and are able to provide grief therapy for survivors. Look for clinicians who are trained in suicide bereavement, because some are not. Support groups, peer-to-peer connection helps us feel less alone and that our challenges are not unique, but shared by many other loss survivors. Again, AFSP has a list of support groups throughout New Jersey that have gone through our suicide bereavement support group trainings, that if you ever are in need of one, you can type in your zip code and it'll show the closest support group to you. And the trauma work, we want to do the work. It's so important. It's so necessary. Grief can soften over time, but the trauma doesn't leave our bodies unless we do the work. A few examples of trauma work: EMDR, DBT, Irit can also touch upon a few as well. Somatic therapy. Suicide loss survivors have trauma rooted in their bodies that will not move unless we work at it. And self-care, this is such a big one. We could do an entire breakout on self-care, just the basics: nutrition, drinking enough water, getting out of bed, eating an actual good meal, making sure I'm keeping up with my doctor's appointments, vitamins, supplements, my health, my comfort, mindfulness, right? Really being present, breath work, yoga, calming the nervous system, anything that works to you, anything that helps you feel a sense of purpose and wellness. This is essential to our healing. And integrating loss into your life. So this is kind of where I'm at today. It's always changing for me. I find it so helpful to be open to how it's changing my healing process and my loss. And it shifts over time. I'm okay with that, but I've learned to balance the joy and the pain. I learned to set boundaries, saying no, saying yes to things that don't suit me, learning to be present in the moment. And of course, always practicing self-care. So just a couple things I want to touch upon on what to avoid when speaking to a suicide loss survivor, because many people don't know how to start that conversation. I know we've mentioned this a little bit before, so they avoid it altogether. Creating that safe, supportive space where a loss survivor can really express their emotions is incredibly meaningful. It could be sitting with them, right? Not saying a word, offering that calm, caring presence can bring great comfort to someone in times of deep sorrow. So we want to avoid giving advice about how they should feel or how they should grieve. Other than reminding the suicide loss survivor to take care of their basic needs, right? Getting up, taking a shower, eating. We want to avoid direct advice giving, right? There's no right or wrong way to grieve and cope with a suicide loss. So instead, we want to use the I statements to offer insight. For example, instead of saying, well, you need therapy, you need to do this, you need to do that, you can say, I can say, right, when I lost my cousin, going to therapy helped me process her death and begin to heal. Have you thought of talking to someone? Have you tried to talk to a therapist? We also want to avoid giving advice about how to tell family members or others about the suicide death. Some people may not feel ready to talk publicly about the cause of death. Also, if there are children involved who have been affected by that suicide death, it is up to the loss survivors, parents, closest family relatives to determine what to tell them, how to tell them, and when. So we want to refrain from offering advice such as, they're too young to hear about this. Just say it was an accident, right? We're going to leave that up to the immediate family. And we want to avoid placing judgment on the suicide. We don't want to refer to the suicide as, a sin, an act of weakness, a lack of love, right? Not only can this discourage others from seeking help if they are also struggling, but it oversimplifies the very complex health issue of suicide. It's also important to not get into disagreements with the loss survivor, right? The loss survivor may place judgments on suicide or use hurtful cliches themselves. And we want to just listen. We don't want to correct them because, again, they're in this process of grieving and mourning. And we want to avoid asking questions about how that person died. It's really important that we don't ask that question. If the loss survivor does not bring up the suicide method, assume they would prefer to not talk about it. If they do mention how their loved one died, we don't want to ask for details. We don't want to get into the gory details. If they do want to talk about that, again, encourage them to talk with that mental health professional in a safe space. And we want to avoid placing a timeline on the lost survivor's grief. I've said it multiple times, this is going to be a lifelong journey, though often well-intended, the phrase is this too shall pass, right? You need to move on, right? You're ready to, it's time. This is going to unintentionally pressure that survivor to move on, maybe before they're ready. And we want to avoid using common phrases such as hang in there, right? This could really activate someone who might be struggling or who, is a recent loss survivor. Avoid saying hurtful cliches such as, this is God's will, this was meant to be. It's better to be quiet and listen than to fill the silence with an unhelpful comment. So instead you can say, I don't know what to say, but I'm here for you. And it's normal to feel unsure, after hearing all the don'ts, what do I say? What do I do? But don't let that stop you from reaching out to lost survivors. Your support and genuine intentions matter the most. So we want to focus on the lost survivor themselves, follow their lead, and then offer your presence without pressure. So how do we start this conversation with a lost survivor? We want to say the person's name, right? Many people kind of beat it around the bush in the beginning and didn't say Danielle's name. They referred to her as your cousin, and we talk about her all the time. And I felt like that upset me in a way, right? They were scared, because they felt like they couldn't say her name in front of me. And I understood why, but I wanted them to. So many people might feel awkward using the person's name, but that only perpetuates that negative attitude towards suicide, and shame that lost survivors might feel. So we want to help keep that memory alive and use their name. Give the lost survivor an opportunity to reminisce, right? To talk about that person. We want to focus on the life the person lived and who they were, not just on their death. And then we want to time it right. We want to wait for a private moment to offer a no pressure conversation to our lost survivor. But again, we want to respect everyone's wishes. They might not want to talk in that moment, and they may not be ready for a while. And that's okay. We just want to continue to keep that door open. We want to say things like, I'm here when you're ready to talk. I know you're going through a lot right now. Can I bring you dinner on Thursday? A specific thing. Can I drop this off at your doorstep? Can I come inside to keep you company? We also want to give them that autonomy and their choice. And we want to ask questions, right? We want to always remember to first ask if they want to talk. If they don't, just say something like, I'm thinking of you. I'm holding you in my thoughts, in my prayers. I'll check in from time to time, right? We don't want to pry, and we don't want to ask details of the cause or method of death. And if they do want to talk to you, we want to ask open-ended questions to really help them explore their feelings and talk about their loved one. You can say, what would you like people to know and remember about Danielle? Right? And then you want to follow the survivor's lead on what they want to talk about and how long they want to talk. And since lost survivors may have trouble concentrating or making decisions in the days or weeks or months after the death, instead of asking, how can I help? We want to give specific tasks, right? Offering concrete examples to, because they may not know what they need. And that was the reality of it. Our family didn't really know what we needed until someone just did something for us. And we were like, wow, that was really helpful. And importantly, we want to reflect their feelings back. This is a form of communication that really involves listening to someone and then expressing their statements back to them so that they really feel like they're being heard. And it's a part of this active listening. If they say, I'm so overwhelmed with planning the funeral, taking care of the kids, thinking about going back to work, you could say something like, it sounds like you have a lot on your plate. You have so much on your plate right now. Let me take the kids to soccer practice. It's really important to remember that recent loss survivors may need that time to process what they're feeling and think about where they want that conversation to go next. So, don't feel compelled to automatically, break the pause, break the silence. Sometimes they just need to sit with their thoughts and have that positive presence with them. And then we want to talk about next steps. After each conversation, we always want to let them know this door remains open, right? If you feel comfortable enough to have this conversation, thanks for talking to me. I'm here for you anytime. You can come to me whenever you need to. And then we want to plan to check in on them too. Again, if you offer to do anything for them, bring a meal, we want to make sure that we're following up. We're being there for them because they're counting on this. And if you feel like you can't, that's okay. Then we want to provide those healthy boundaries too. And going back to offering practical help, people often find it hard to ask for help or may not even know what kind of help they need. So especially in the early days following the loss, for that reason, simply saying, let me know if you need anything. It may not be helpful because, again, I may not know what I need. So just some few examples, right? They might not all work for you, but depending on your relationship with the lost survivor, these are just some ideas. What everyday stressful things can you help them in short term? Running errands, picking up the groceries, ordering food, babysitting, walking the dog, dropping off a meal, right? Organizing a meal train, doing the yard work, taking simple tasks off of their hands, doing the laundry. So before we conclude, I wanted to just give some resources here. So these next few slides are going to be a bunch of resources. You can take a picture. I can also provide them to Irit afterwards, but please take a moment to look at them. Super important. So these are just general U.S. Suicide loss support groups, resources. The American Foundation for Suicide Prevention, we're on there. The Alliance of Hope for Suicide Loss Survivors, Friends for Survival, the American Association of Suicidology, and TAPS, which is specific support for military and veteran suicide loss.
Deanna, maybe we can mention that people can take a screenshot if they want.
Yeah, absolutely. Please feel free. I'll leave it up for a couple seconds. Okay.
Yep.
And I'll also put them in the chat too. Specific AFSP resources and programs that I work with. We have Healing Conversations. So this is a one-on-one peer support program. So you work with our Healing Conversations trainers, and they have the same loss as you. So if you are, if your loved one died by suicide and this is your child, you will talk to another mother or another father who lost their child as well. It's a great one-on-one conversation in the days or weeks or months following a suicide death. And it just helps that person feel like they aren't alone and how to start this grieving journey. Our International Survivors of Suicide Loss Day, this is actually throughout the world that we host the Saturday before the American Thanksgiving, where survivors come together for connection, stories of hope and healing. And it's such a powerful day. And it's so meaningful to those lost survivors who attend. And then, as I mentioned, we have that Find a Support Group button. So anywhere that you are in the US, you can put in your zip code and you can find a support group closest to you. And then we have lost survivor videos. So this is part of what we call our healing journey. These are specific videos where our lost survivors talk about what has worked for them. Where are they within their grief? How can we support other lost survivors? And then specific New Jersey support for those of you within New Jersey. We want to first mention the TLC, so the Traumatic Loss Coalition. I know Maureen Brogan, the director, was on here with us today. This is an amazing support that you can use within your schools and communities. So this is a statewide network that provides support and education following a traumatic event in a school, like a suicide, a homicide, an accident, or illness. And then we have the HOPES program as well. So this supports families after the suicide loss of a child. And then we have the Prevent Suicide NJ website. This is a hub for all suicide prevention resources and postvention resources that are free that you can download. And there are trainings on there too that are available. think I have just two more. Then we have specific to youth and family support, the Dougie Center. So this is grief support for children, teens, and families. They're amazing. And then the Comfort Zone camps. These are camps and resources for children and families impacted specifically by suicide loss. And then just some helpful general resources. We have Psych Today, MHA, Mental Health America, findtreatment.gov, SAMHSA as well. I know NAMI isn't on here, but they're another great resource too. So many different avenues that you can really utilize that have free resources and trainings. And lastly, just two books that I really wanted to just recognize. We have films and books for loss survivors on our website that are free that you can download again. And the Alliance of Hope has really great books for suicide loss survivors too. So I will try and put these in the chat as we're opening up for discussion. But Irit, thank you so much. I'm just honored to be here and I'm looking forward to a great discussion. So thank you all so much.
Thank you very much, Deanna. This was really very, very good. And I really thank you for this.
Welcome.
I wanted to, before we open it to the questions and the discussion, I just wanted to mention two other books that I thought were particularly helpful. One is Shirley Avrami. I can also put it afterwards in the chat. Shirley Avrami's book, If He Had Only Died in the War, which is how suicide impacts family members and how hard it is in comparison to, for example, losing someone to a war. How much easier that would have been, in a sense, how much more difficult and complicated it is. And the other book I had in mind, I'm blanking on right now, so maybe it'll come back to me in a minute. Thank you so much, both of you, Adele and Deanna, and let's open it up. Felix, can you help me with some of the questions, comments? And we can also maybe, I can't see people raising their hands on the gallery, so if you can just help me see what we have.
So lots of comments. I don't see any specific questions asking for resources, but I do see Mary Jean Weston raising her hand. So go ahead, Ms. Weston.
Thank you very much. First of all, I want to thank all of the presenters. It's been a pretty impressive afternoon. And Deanna, it's nice to know you. I'm in New Jersey as well, so good to hear about that. I put in the chat, but I wanted to highlight the fact that in addition to all of the great resources that have been mentioned, 988 is available 24/7 throughout the country and is available to survivors of suicide, to loss survivors, as well as obviously to people who are in crisis, emotional crisis, suicidal crisis, or substance use crisis. I'm pretty familiar with this system here in New Jersey, particularly, but it is a nationwide option. And I would encourage you, Deanna, in the future to include it in your slideshow, just as a reference point, because it's available to anyone by phone. That's the easy one. You type in 988. It's also available by text and through a chat system. So I did want to mention that, and I put the link in the chat for anyone who wants to look more at the website. Thank you for taking my request.
Thank you very much. I just wanted to mention we actually included the number, the 988 on our flyer. And I was wondering if, Diana, if you know if the launch of 988 made a difference in terms of the statistics.
Yeah, so we work, we're not a part of 988, but we work with them. I don't have specific data, but we did see an increase in the calls, specifically in New Jersey, where people were reaching out via call and text once it became the 988 number about 3 years ago. So there is a need for it. There's definitely a need for more funding as well within not only New Jersey, but within the country. But it is something that needs to stay, and it is very important.
Thanks.
And then we have Felicitas.
Yes. Hi, how are you?
Hi, nice to see you.
Thank you, Irit, for putting this, organizing this webinar today. I am very moved by the heartfelt that we shared, Adele shared with us. In my case, I lost very close relatives by suicide, and my mom was in a plane crash, which is a traumatic loss for sure. But I would like to share with you some of the information I've been studying diligently about suicide. And Dina, you probably know that, is that how you pronounce your name?
Deanna.
Deanna, yes. As you know, the International Association for Suicide Prevention has made a campaign called Changing the Narrative on Suicide, when you mentioned about changing the narrative. And that campaign, instead of doing it for 1 year, they've been doing it for 2 years. So that's one thing that they had several seminars, both in English and in Spanish, and it was very stimulating. That's one thing. Then since I don't think I can stay with you until very end, I'd like to share with you a couple of programs that are out there that you may know. The program called Act for Life, which is supported by the U.S. Department of Veteran Affairs. It's called Using Acceptance and Commitment Therapy to Prevent Suicide and Build Meaningful Lives. That's a very complete program and very interesting. You may know about it. The other, there is a statement, the second thing I'd like to share, a statement by the American Academy of Child and Adolescent Psychiatry, where, as you all know, suicide is contagious. So they made a policy statement on the impact of suicide, how that can impact on social media. And there is a whole program in regard to that, media and social media and suicide. And of course, we are part of media, right? A program that is very, very extensive. And at the Mount Sinai Hospital, we have, because I'm part of the Department of Psychiatry at Mount Sinai Hospital, we have Dr. Gallenker and his group, and they have a narrative crisis model of suicide, which really goes in detail what is chronic suicide, chronic, the chronic ideation, suicide ideation, then the subacute suicidal, and then acute suicide crisis, which is already a syndrome. And he really offers, because you were talking about, Irit, you were talking about safety plans. They really have a program for safety plans. I think you may know about this. And the last, there are many more, but I don't want to monopolize the time.
Yeah.
The last thing that I like to share with you is there's an interesting program called Evolution of Zero Suicide, which is by the Henry Ford Foundation, and that has developed, and it's still on its way to go. It's becoming international, and I suggest for you to look into it. Okay, thank you.
Thank you so much. Thank you, Felicitas. I'll take the opportunity while Felix is looking for the next comment question to throw in something that I think is, I just would like to have it out there. While we're talking about how important it is to find peer support and these one-on-one conversations that your organization offers, Deanna, where people speak with someone else who experienced a similar kind of loss through suicide. I just want to throw it out there to the mental health professionals amongst us that it is my very strong opinion that we should be very, very careful about disclosing personal loss through suicide to our patients because sometimes it actually can make people very uncomfortable. I was made aware of it by a patient who came to me after she felt she had to leave her relationship with her very previously meaningful relationship with a therapist after the therapist confided that she had also lost a child through suicide, which made it very difficult for my patient, as she said, to speak because all of a sudden she had to keep in her mind wondering if her feelings are going to be hurtful to the psychologist, if she's going to be judged for these feelings because the other person is dealing with a similar situation. And it made it very difficult to be fully comfortable in disclosing everything that she was feeling. So it's a balance there between finding peer support, which is so important, and at the same time, this cautionary comment for those of us who are working as professionals with suicide survivors. Felix, do you have another one?
I did not see anyone. One thing that I want to mention about 988, since I was involved in the rollout of 988 here in Texas, in my prior job with the state of Texas, is that since the launching of 988 in July of 2022, 988 nationally has handled more than 14 million calls, texts, and chats, which is nearly doubled the national calls compared to the old 1-800 system, which is amazing. It's great that people are able to connect with someone. So the success of 988 has been clear in getting people to reach out. The major bottleneck, unfortunately, is that while the call centers have scaled in an amazing way, and there are people answering the calls, the response has not. So the mobile crisis teams, the people who would be available for stabilization centers, are not there.
Wow.
So one of the main goals, of course, of 988 is to divert from 911 to a mental health resource, and not have to have PD, police, to respond to a mental health call.
Right.
And to have mental health resources to do that, or to connect someone to a mental health resource. And unfortunately, what is happening is that even though the person is being connected to or speaking to someone on the phone, at the end of the day, they're still ending up being connected to PD, and
Wow.
PD is the one ending up to respond, because even though we're scaling the connection to someone, what is out in the community is still not available.
Wow. That is shocking.
And I think we have Avi Appelstein, depending on which coast, up next, sir.
All right, I can't hear you so well, but it's okay that I'm talking now?
Yes.
Okay. First, thanks very much for the sharing, because it's always touching, of course. I have a question to you, Irit. I just checked the statistic. In Israel, there is 1 to 18,000 persons, one is committing suicide. In the United States, if it's 50,000, if I understood correctly, it's every 8,000. So it's over a double. What would be your explanation for that? Or is there any research? I guess it's something to do with the loneliness, but it's the loneliness of possibility for people.
With the what? I'm sorry, Avi?
With loneliness.
Loneliness.
Loneliness. Because I think one of getting desperate. I'm also a therapist, and I know. Luckily, I didn't have any client that committed suicide. I had a peer group that somebody was committing suicide from second generation.
Yeah.
But and somehow I knew that it can come, but. I'm really wondering, because in Israel you have so much trauma there in Israel. Actually, you have much more pavement to much more reason to commit suicide, and still, I think it's much more resilience through this through that. And I guess that something is to do with society getting lost, feeling alone.
I totally agree with you. I think that as an Israeli who is living in the States for many years now, I live here now since I did my postdoc because of a decision that either my husband gets the position he wanted, or we go back, or I go back with him to Israel, and you can see who won. Yeah. But I think that life is very significantly different in these two different cultures. And I think that what is here now referred to by the Surgeon General as the epidemic of loneliness it is very, very different there. It is possible for a person here to be home for a week and essentially nobody will notice that they haven't seen them because, even good friends don't speak on a daily basis, don't speak twice a week, don't see each other very often. It is very different there. Neighbors see each other, talk to each other. It's a very different kind of a culture still. Even though, it's changing, it's already very different than it was when I was growing up there or before I came here. But I think that we have lost, in this very sort of achievement-driven and self-growth-driven society that we live in this country, we have lost something profoundly protective and valuable in terms of the close-knit connections with other people, and that require a certain choice about what you put your time into. Writing another article, going to the gym, much as these things are important, or also making some time to get together with family, with friends, to just hang out, to just talk, to just be together. I think that we might have to make some changes that are not just in the field of mental health, but really more widely sort of preventive changes in sociocultural ideals and values and how we educate young people about what's important.
If I may, having said that, there's an alarming rise of suicides now in light of the past 2 years, in light of the experiences that so many people have been having during the war, as part of the war. So I would be curious to know Avi, when your statistics are from.
The statistic is from, it is the Israeli statistic. I just had another program about somebody who's a specialist for that. And if you will look in the internet, that will be also the answer. Around 500 people, 80% men.
But what date? From when?
When was the survey conducted?
I think last year, 22 years ago.
I wouldn't be surprised that there's a big difference now.
Yeah, I wouldn't be surprised if it was conducted before October 2023. It would be maybe a little different, but I still wouldn't be surprised if even after that there are differences between Israel and the United States. I think that these are very, very important issues that have to be addressed by us mental health professionals in particular in terms of translational research. I think we don't do enough to be vocal in a public sense and in the places where policies are being determined about what we know from our studies. I would like to, before we have to wrap up, I would like to thank, first of all, our speakers again, very, very much from the bottom of my heart. It was really such an honor to hear you both. And Felix, I want to thank you so much for all the trouble that you went through and all the trouble that I put you through in the process of creating this program. And it's really been a pleasure working with you. And
It's always a pleasure to put this program together and to collaborate with you and the working group on this.
thank you, Felix. Thank you very much. And thank you, everybody who chose to spend the last 2 hours with us. I know how busy we all are, and we appreciate it very much. And I'm just hoping that this kind of a thing creates certain, what is it that a stone creates in the water? Those
Ripples.
Ripple effect.
ripples, right, ripples, and that we can take some of the very important information that Deanna shared with us, and Adele, the insights that Adele shared with us to wherever we are, personally and socially and professionally. So thank you all very much, and be well.
I believe our chair may be with us still, Dr. Holly Shaw, who may want to give us a closing statement. I want to also remind everyone that the NGO Committee on Mental Health is always welcoming new members. So I have put the URL there for you all to click on it if you're interested in becoming a member of the NGO Committee on Mental Health. And you can find more information about us there. And I pass it over to Dr. Shaw for
Felix, can you keep the chat for us to look at afterwards again? Is it possible?
Yes.
Great.
I
And the
can
program has been recorded and will be put on the.
Yes, everyone who actually not those who did not show, but those who attended, I always send them the link so they can access it. It will be posted on our YouTube channel.
Wonderful. Thank you so much.
Thank you, everyone.
Thank you, everyone. Thank you, Dr. Felsen and Dr. Torres, for your unwavering assistance in making these programs meaningful. I just want to remind you that March is the Commission on the Status of Women, our program, which you will receive information about and will be on the website, is March 12th. In April, our program will be on refugee and immigrant mental health. In May, children and youth. In June, LGBTQ plus, and we have programs scheduled throughout the year. And as Dr. Torres said, I'd encourage anyone to go to the website and join in whatever membership capacity you would like. We're very motivated to get this group going again in a vital way, and there's a lot of information and resources to share with all of you. And thank you for those of you who work so energetically to spread the word. We'll be distributing a newsletter in the next couple of weeks. We're just putting final touches on it. And the meeting in March will be in person and hybrid. The other meetings are probably all going to be virtual. That seems to be the way the membership wants to continue. But we look forward to getting together in person on those occasions that we can. And next month will be an opportunity to do that. Thank you all very much. And it was good to see everyone.
Thank you.
Bye-bye.
Bye-bye.
Bye.